Thank you very much. So I think we'll make a start. So I'll invite Dr. Ayaz Mir to come and chair the session. So my name is Dr. Sayyid Waqas Imam Bukhari. I'm a consultant hematologist at Shaukat Khanum Memorial Cancer Hospital. And I'm very happy to be joined by Dr. Ayaz Mir. He's a consultant hematologist and a BMT chief at Shifa International Hospital. This session is the bone marrow transplant session. We have three excellent speakers with excellent talks lined up, and we'll make a start. So the first speaker, who needs no introduction to everyone here, is Dr. Rahil Iftikhar. He's a consultant hematologist and transplant physician at Armed Forces Bone Marrow Transplant Center in Rawalpindi, and is also currently the secretary of the Pakistan Blood and Marrow Transplant Group. So he's going to be talking about the role of transplantation in myelodysplastic syndrome. Over to you, Dr. Rahil. Thank you.
So thank you very much. I'm indeed extremely honored to be presenting here today in front of all the respected distinguished faculty. There are no conflicts of interest or disclosure. So once I was looking at the topic and I was looking at different famous celebrities who had myelodysplastic syndrome, so I came across this courageous lady. So any idea who she is? So Robin Roberts is a host of the famous show Good Morning America. She had myelodysplastic syndrome and she received allogenic stem cell transplant for MDS in 2012 and is doing wonderfully well up till now. Despite a number of approved therapies for myelodysplastic syndrome in last decades and approval of venetoclax for higher risk MDS around the corner, all these treatment remain supportive and palliative. And in 2024, allogenic stem cell transplant remains the only curative treatment options for patients of myelodysplastic syndrome. And if you look at CABMTR data, this MDS MPN category stands at number 4 among all the transplant indications and second to AML for allogenic stem cell transplant. But despite this, the survival outcomes for myelodysplastic syndrome for both match-related and unrelated donor remains less than desirable. So overall survival hovers around 40 to 50%, which is significantly low as compared to other benign and malignant disorders for which hematopoietic stem cell transplant is being done. And if you look at different factors which affect survival post-transplant, so this study by Della Porta, which was published in 2014 in Blood, identified recipient age, ACTCI score, type of donor, and conditioning regimen as potentially adverse prognostic factors which affect transplant outcome. And once we move forward with our talk, we'll see that whether this has changed over last decade or these factors remain same. So as for any transplant indication, once we are considering transplant for a disease, we have to identify that whether the patient merits transplant and what is the risk once we take this patient to transplant. So we all know the clone wars, but for myelodysplastic syndrome, it is war of clones. As the disease progresses from one stage to another, different adverse risk genetic mutations are acquired, which not only confers resistance to treatment, but also actually propels disease progression into a leukemic phase. So IPSS-M was introduced, identifying these 16 genes, which are actually known to have prognostic impact in myelodysplastic syndrome patients. Each gene has a specific hazard ratio and the model weight was given proportionately, and as expected, TP53, MLL, and FLT3 are topping the list. More importantly, once patients of IPSS or RIPSS are restratified using IPSS-M, 1/3 of the patients would be either upstaged or downstaged. And most importantly, most of these patients would be upstaged, So we have risk classified a patient as low risk MDS with IPSSR. We do an IPSSM, and the patient will fall in category of high risk patient. But this IPSSM is applicable to us. At our center, we have 512 registered MDS patients till June 2024, and we were able to conduct NGS only in 21 patients. This is 4.1%. The cost of two different tests which are offered is 1.5 lakhs and 3.5 lakhs. If we are doing a test of 1.5 lakhs, we are not able to test all the genes because the RNA-based testing is not done. So the cost is a major prohibition once we are applying IPSS-M to our patients. And we have to rely on our IPSS. And uh, more importantly, sometimes it is not our IPSS. It is only the cytopenias and morphology. Because what we have seen that the yield of normal cytogenetics from all the reference lab in Pakistan is markedly inferior as compared to what we see in Western data. So our cytogenetics also needs to be improved. So in most of the circumstances, we would be rely only on cytopenias and morphology to risk classify our MDS patients. And once we are not able to risk stratify them exactly, we are not able to differentiate the good, the bad, and the ugly. And the primary point of selecting a patient upfront for transplant and risk stratifying them remains a problematic issue. If you look at the standard recommendations and guidelines, high risk MDS is a standard of care indication for allogenic stem cell transplant. For low risk MDS patients, those who are failing HMA or those who have refractory cytopenias are considered as one of the candidates for transplant. And this is a separate entity of hyperplastic MDS or post-cytotoxic MDS, previously called as therapy-related MDS, which actually qualify for transplant indication as upfront. For high-risk MDS, there are a number of prospective randomized clinical trials which have documented the efficacy of upfront transplant as compared to conventional supportive care and have documented superiority of transplant. So for high-risk MDS patient, transplant remains the standard of care indication. For low-risk MDS patients, the conventional teaching and standard recommendation is not to offer them transplant upfront. And for selected patients with profound cytopenias, evolving mutations, lack of response, if they are transplant eligible, they can be taken to transplant. However, is this timing and referral pathway correct for our MDS patients to be referred to transplant? This is a study which actually collected 2 years data, 2010 and 2011 data from all the MDS registries globally and identified 16,500 MDS patients who were high risk. Out of these, only 20% were eligible for allotransplant. And out of these 20%, only 1/3 received transplant. So for high-risk patient, only 7% of the patients received transplant. And if you look at overall survival of 40%, that means we are diagnosing high-risk MDS and we are curing only 2.5 to 3% of our MDS patient by adopting this strategy. So once this study was published, EBMT looked at the retrospective data of low-risk MDS patients and looked at it that how they fared. So 246 patients were evaluated in this study, and the 3-year overall survival was 58%, which was better as compared to overall cohort. And the adverse risk factors for progression-free survival was high blast percentage and donor recipient CMV0 status. And the study concluded that low-risk MDS patients have a better outcome than those with higher risk after transplant. This was followed by another randomized trial, which was conducted in China, comparing transplant versus no transplant in low-risk MDS patients, documenting superiority of early transplant for this cohort. However, recently in 2023, ASTCT guidelines for MDS were published, and low-risk MDS is still not recommended globally as a standard of care treatment option for MDS patients. Now, once we have seen the impact of upfront disease status, what is the impact of different other factors which were identified in the study by Della Porta. So cytogenetic abnormalities, if they are high risk, have an independent poor prognostic significance. And out of these, we know that TP53 fares the worst. And there is always a discussion that whether TP53 patients should be transplanted or not, because the overall survival remains dismal in this cohort. So this was an interesting work that was published by Kusuri et al. In this year, Blood Advances, and it actually risk stratified TP53 patients into three categories. Those who had a monoallelic TP53 without complex karyotype, and they suggested that these patients should be offered transplant if the standard criteria is met. For those with biallelic TP53 with or without complex karyotype, but a very good functional status, should be considered transplant on case-to-case basis. For HCT-CI score of more than 4 should not be offered transplant. On the basis of all these findings, EBMT took the lead and they actually devised a separate transplant risk score. We know that EBMT has a risk score for hematological malignancies, but EBMT transplant risk score for myelodysplastic syndrome were devised on the basis of all these risk factors, which documented its prognostic significance. We are at center, our center are now using this score for last couple of years, and we hope to see and compare that how our patients fare at our center as compared to EBMT data once this score is applied. So once we have identified the risk status and indications of transplant, whether improving disease and performance status prior to transplant does make a difference or not. There was always a debate that whether patients with high blast percentage should be cytoreduced or not. And the debate arises because all the previous data came from intensive chemotherapy regimens. And we know that if you treat myelodysplastic syndrome with intensive chemotherapy, these patients will have prolonged cytopenias, they will not regenerate. So with the advent of hypomethylating agent, the current recommendations by MDS expert panel is that if marroblast is more than 10%, cytoreductive therapy should be offered. And this is backed by the evidence that now we are not using carpet bombing, we are looking at snipers. So if you achieve cytoreduction prior to transplant in MDS patient, and somehow you are able to achieve complete remission, the outcomes are as good as you can expect. And out of this cohort who achieve complete remission, if we are able to get NGS MRD negativity or MRD negativity status, the outcomes are even better. So pre-transplant cytoreduction should be offered if available. This is what our center is practicing. So once we diagnose a patient as high-risk MDS and we start with donor search and matching, we do offer them either HMA alone or in combination with venetoclax, because as we know that venetoclax is still not approved for high-risk MDS, and there's a randomized Verona trial that is ongoing comparing AZA alone with AZA plus venetoclax. So what should be the conditioning intensity? Big guns or no big guns, MAC or RIC? This is always a burning question for myelodysplastic syndrome because most of these patients are elderly. Even if you look at CABMTR data, there is a split. So a good number of patients have received MAC, a good number have received RIC, and within these, each component, different conditioning regimens are used. So Nicholas Kruger et al. Looked at this aspect, and they did a randomized trial that was a RIC-MAC trial with a median age of 51 years, and they randomized MDS high-risk patient to receive versus FB2. The outcomes of this trial were similar between two arms, but there was a critique that BUSI was used as a conditioning regimen, which we know is an intensive conditioning regimen, especially for older patient, and is associated with increased non-relapse mortality. Later by Scott Bart in BMT-CTN 0901 trial. And FB2. So those regimens were used, which are actually used in real world practice for treatment of myelodysplastic syndrome. And in this trial, RIC was associated with increased relapse incidence, a lower non-relapse mortality, but an inferior overall survival. So this trial use a tailored MAC regimen. It is better than using a RIC regimen. And now we are moving towards novel regimens with a dual aim of pre-transplant cytoreduction and to reduce toxicity. So decitabine based and CPX351 based protocols are being tried and the results are awaited. The choice of RIC and MAC regimen is actually, there's no clear-cut answer to that. If you look at this systematic review and meta-analysis that was published in BBMT in 2018, there are different regimens which have almost comparable efficacy. There is a recent paper suggesting that Flu-Mel as a RIC regimen is better than FB2 with better progression-free survival, but different institutes are following different practice. Our practice is to use Bucy with or without ATG for patients who are less than 40 years, FB4 with ATG if the patient is 40 to 50 years, and more than 50 years, we use either FB2 or Flu-Mel, and it is a physician preference-based discretion. So selecting a right donor is also equally important, especially in our part of the world where we are seeing MDS in younger patients. Uh, Germline mutational testing should be incorporated as a part of pre-transplant workup, especially in younger patient if it is available. We know that inherited marrow failure syndrome do test for that, and it costs around $300 if we send it to Invite UK. So for selected patient, it should be offered because if the patient has a germline mutation, it impacts what conditioning you will be using and what donor you will be selecting. Regarding the choice of donor, match-related donor transplant remains the upfront preferred options, followed by MUD or Haplo, and MDS remains a treatment in which still match-related donor is superior to Haplo. There are a lot of data coming out of their equivalency, but still in MDS, all the data suggests that match-related donor is superior to Haplo. Regarding graft source, PBSC or bone marrow harvest, both can be used. So it is an exhaustive list of all the trials which have compared PBSC or bone marrow harvest. So both of them have their pros and cons, like increased GVL with PBSC, delayed engraftment with bone marrow harvest, but overall, the results are comparative. Regarding GVHD prophylaxis, calcineurin inhibitor with MTX remains the standard of care GVHD prophylaxis. Rabbit ATG can be offered as per EBMT recommendations if you are using a PBSC, if there is a high risk of graft versus host disease, or you are using a MUD. PTSI remains a preferred choice for Haplo, but it is still not a standard of care for MRD, although it is being used in different centers. For relapse prevention, our center is using this algorithm. We actually do a split donor chimerism at day 30, 60, 90, 120, and 180 days post-transplant. And if there is a mixed donor chimerism, we actually taper immunosuppression or abruptly stops that. But if there is evidence of either molecular or cytogenetic or morphological relapse, we intend to intervene early with a chemo DLI approach. And for chemo, we use azacitidine monotherapy, 37.5 mg per meter square for 5 days. The role of maintenance therapy after allogenic transplant remains unclear. There is no standard recommendation. However, there is data to suggest that for certain subgroup of patients, decitabine or azacitidine maintenance can help in high-risk cohort. But again, it is not a standard of care recommendation. So I'll just show our data. We have done around 1,700 transplants overall for all the disorders at our center. And this year, we have done 170 up till September 2024. These are different transplant indications. Initially, our center was focusing more on hemoglobinopathies and bone marrow failure. But now gradually this leukemia, lymphoma, and plasma cell disorder cohort is expanding. And for MDS, we have done 2% of all the transplant. These are 41 transplants. The median age of our cohort was 30 years. So a lot younger as compared to what our Western data has suggested. 78% were male and 83% of transplants were done for high-risk patients, and they were deemed high risk on the basis of IPSS or lately on our IPSS. Batch-related donor transplant was done in 93%, haplo in 7%. There were 3 haplo transplants. Stem cell source, our center has a preference for bone marrow harvest, so we use bone marrow harvest. And we use MAC conditioning intensity in 93% and RIC in 7%. The conditioning regimen which we used mostly was either BuSci or FB4. This 7% BuSci-MEL is a pediatric cohort. They use BuSci-MEL. And for other, there was RIC or haplo protocol. The cumulative incidence of graft versus host disease was 22%, both acute and chronic. The overall survival was 47.5%, and disease-free survival was 42.9%, but we are early in our data. If you look at median follow-up time, that is 320 days, that is 1 year. So this curve is likely to drop once we move forward. I'll conclude by saying that the transplant of MDS is a tale of unmet needs. The use of IPSS-M should be preferred once available. We should be considering early transplant, especially in our population, once we are not able to risk stratify as per IPSS-M. Pre-transplant cytoreduction should be offered. MAC conditioning if the patient can tolerate. Haplo-identical in absence of MRD, but it should be an early haplo and early interventions for relapse. So thank you very much. I'm indebted to my team who provided me all the data and helped me in presentation. Thank you very much.
Thank you, Dr. Rahil. We'll take questions at the end.
Dr. Natasha, Professor Natasha Ali is our next speaker from Marathon. Everybody knows her. She's our pride, and she's going to present very important supportive care topic, infective complications in bone marrow transplant patients. All yours.
Assalamu alaikum and good morning, everybody. Thank you very much for the kind introduction, and thank you to the team at Shaukat Khanum for giving me this opportunity to discuss a very important topic. And while I was making this presentation, I thought I should maybe apply for an FCPS in microbiology for the amount of research that went into preparing this presentation. So I have nothing to declare. A couple of slides on the frequency and prevalence of transplant infections internationally and nationally. We'll discuss the risk factors and timeline of infections in transplant patients, the type of infections that we see, the treatments and rationale. And then I'll present some local data of infections in transplant patients, mainly studies from my center and studies in Pakistan. And of course, it's very important to discuss prevention and the role of antibiotic stewardship program. And then I'll summarize. So we all agree that transplant is a potentially curative treatment for many malignant and non-malignant hematological disorders. While we have made advances in a lot of areas in the stem cell transplant program, infections, severe type, are frequently encountered, and it is a very, very hard truth complication of stem cell transplants. There is a wide complex of interplay between a lot of factors that lead to complex interactions and that lead to infections. And these interactions are between several factors. This include the underlying illness for which the patient is undergoing to transplant, the type of conditioning regimen that we're using, the degree of HLA matching, so haplo, match unrelated, match related, whether or not the patient has GVHD, and the type of transplant. So if you look at the conditioning regime and if you look at the graph over here, the more myeloablative the conditioning regime is, you're exposing your patient to a lot of mucositis and skin breaches, and that leads to profound neutropenia, leading to more risk of infections. And as the conditioning regime goes down or the intensity goes down, the risk of infections also goes down, because mainly it is this, which is neutropenia. The less degree of neutropenia, the lesser risk of your patients developing infections. The other risk factors, if you talk about graft source, then peripheral blood, because the neutropenia is short-lived, the risk of infections also decrease. Malignant conditions, mainly acute myeloid leukemia and acute lymphoid leukemia, they predispose the patients to the risk of infections because anti-leukemic agents decrease the utility of the drugs that we give for prophylaxis of the infections, mainly by decreasing the antigen presenting and decreasing the antibody response to different antigens, and that leads to infections even in the absence of neutropenia. The preparative regime, the presence of GVHD because you're going to give them high dose steroids, and of course the access, whether it's peripheral line or it's a central venous access. So all of these factors, neutropenia, immunosuppression, and mucositis come in the middle and play with all of these factors while the patient is admitted in the unit. So the timeline of infections can be divided into three phases: pre-engraftment, post-engraftment, and the late phase. So in the pre-engraftment phase, it's mainly the gram-negative bacilli and the gram-positive organisms that come into play, and the encapsulated bacteria come later in the stages. When you talk about fungus, throughout these phases, Aspergillus tends to stand out, while in the initial phase, it's mainly Candida. And because of good prophylaxis with Septran, the incidence of PCP is going down, but we do see breakthrough infections or, infections in the later stages of the post-transplant period. When you come to viruses, it's mainly herpes simplex that predominates throughout the transplant period. And mainly it is the CMV or the cytomegalovirus that we tend to look out for. And we do that due to in better diagnostic modalities that are present these days. So what is the armamentarium that we have now for the treatment of these infections? So we're well balanced with the prophylaxis that we used. So for viruses, we use acyclovir. Fluoroquinolones, no matter what people say, still predominate in the prophylaxis of pre-transplant or post-transplant infections. And for fungus, it's the triazoles that we use most commonly. The Dermovir has recently popped up for the treatment of CMV, but at the moment, this is not available in Pakistan. And when CMV does happen, we use valganciclovir or ganciclovir to treat the infection. So let's talk about bacterial infections. BSI or bloodstream infections, the incidence is anywhere from 20 to 30%, and this happens either in the early transplant or mostly in the post-engraftment period. So up until 90s, 80s, and 1970s, it was the gram-negative bacteria that used to predominate in BSIs. But due to better use of the antibiotic regime, it is now the gram-positive bacteria that come out more in the BSIs as compared to gram-negative bacteria. The resistance rates of enterococci and mainly gram-negative bacteria, especially the Enterobacteriaceae, Klebsiella, E. coli, are very, very high. And if not treated preemptively, then they're associated with very, very high mortality. Pseudomonas and Acinetobacter, a hard reality. Although they are less frequent causes of BSI, but once developed, they are highly, highly resistant. And talking about resistance, this is something that we come across very, very frequently nowadays in our patients. So antimicrobial resistance is responsible for, look at this figure, 1 million deaths annually. And this is a US quoted paper. And this then contributes to considerable amount of economic cost when you're treating such patients. And our patients, our transplant patients, are uniquely vulnerable to AMR because they are in frequent contact with the healthcare settings. They are frequently exposed to antibiotics because of their immunocompromised status. They undergo prolonged phases of neutropenia. So not just transplant, but they receive treatment also for their underlying disorders. And of course, when you give them immunosuppression for a very long time, they end up with an immunocompromised status. So very, very high rates of AMR in transplant patients. And if you talk about two bugs that come up very frequently, one is the extended spectrum beta-lactamase producing Enterobacterias, which are this. And if you look at the mortality associated in transplant patients, look at the data. One of the study over here has quoted approximately 78% of isolates that were seen in bloodstream cultures when their patients got febrile. And if you look at the mortality, it is very, very high, approximately 37%. In fact, some of these studies have even quoted mortality as high as 50% if ESBL is isolated from the blood culture. And coming to the next most frequently isolated organism, it is carbapenem-resistant Enterobacterales. And this, once identified, sometimes even poses as a death certificate to the patients. If you look at the mortality here, it is approximately 50% in all of the studies that have been quoted over here. Back in the days when we were isolating CRE in our transplant patients, this was in early 2014 and 2015, we also used to have a very high mortality rate if a neutropenic patient had isolated CRE in the blood culture. But slowly and steadily, our ID colleagues and our microbiology colleagues helped us identifying these isolates with a good combination of antibiotics. And now these patients, if at all they do show up, CRA in the blood culture really do well with the combination of antibiotics. C. diff, cannot ignore this. It is a substantial clinical burden, frequently seen in hospitalized immunocompromised patients because they are, again, highly exposed to antibiotics. This is responsible for about 20 to 25% of antibiotic-associated diarrhea and up till 75% of antibiotic-associated colitis. But the drug that we treat C. diff with is oral vancomycin. Patients respond very well to this dose. Our pharmacy colleagues also help us in titrating the dose when the adequate response is not coming up. But vancomycin given orally, 125 milligrams 4 times or 3 times a day, does pretty well in these patients. So the symptoms resolve in 2 to 3 days, and they become culture negative in the next 2 weeks if given appropriately with the right levels. Fungal infections. Very, very commonly, most of the studies popped out AML as the underlying cause of fungal infections, if at all they're isolated. And this is because of prolonged neutropenia and, of course, prolonged lymphopenia as well. In patients who develop GVHD, and if they're kept on prolonged steroids, then this can also lead to fungal infections. Steroids is a harboring factor or a major risk factor for the development of fungal infections and match-unrelated donor transplants. These are the highest risks that pose into the development of fungemia. What to order? A CT scan. If you have a pre-point organ that you want to look for, then CT scan with contrast. But otherwise, galactomannan and 1,3-beta-D-glucanases have now, replaced scanning of these patients. So galactomannan is sensitive in diagnosing aspergillosis, whereas 1,3-BTG can give you whether the patient has either candidiasis or aspergillosis if it comes out to be positive. Direct specimens, like a specimen from bronchial alveolage fluid, you can do direct PCR testing also on these specimens to isolate fungal infections. But once you start treatment, it has to be periodic evaluation, of course, counseling of the patient and drug monitoring, and a multidisciplinary team needs to be involved. What is the armamentarium that we have currently to treat fungal infections? So almost all of these drugs are available in Pakistan, and the use depends on the risk of invasive fungal disease. So the primary prophylaxis will decide whether your patient is at risk for invasive fungal disease, whether it's high risk or low risk. So all of these drugs, except for a few, are available in Pakistan, and all the forms, whichever drugs are available, all the forms are available in Pakistan. Although this part of the table says that therapeutic drug monitoring is important in some of the drugs, we don't have the expertise, and the response that we usually look for is the clinical response in the patient. So what are the common fungal infections that we see? Yeast is mainly Candida and Trichosporum, which is rarely, but we very, very frequently see Candida. And actually, fluconazole or voriconazole as an alternative therapy does pretty well to treat these infections. When you talk about moles, we see all of these. We see Aspergillus, mucormycosis, Fusarium. And in all of these fungal isolates, voriconazole does the job well. So we're pretty well balanced as far as treatment of fungal infections are concerned. Voriconazole may become erratically unavailable sometimes, but then you can fall back on your very famous amphotericin if these are not available. But usually voriconazole is a pretty good option to treat mold infections. So Nausheen is going to talk on cytomegalovirus monitoring in the next session. So I've purposely not touched upon CMV in detail, but just a couple of sentences. What we're dealing with these days is a probable versus a refractory CMV infection in our patients, because sometimes we do see that the virus persists after 2 weeks of appropriately dosed viral therapy. We don't have the expertise to differentiate between the two because we do copies per ml assays, but we don't do log per 10 ml assays. So, refractory needs to be your clinical judgment, but probably refractory, you can still do that if you see persistence of viremia, especially in the context when there is GVSD present as well in the patient. Something that we do see are adenovirus infections up till 20% of the patients in the first 3 to 4 months. Presence mostly in the pediatric population rather than adult. Main risk factors are the T cell depletion, of course, your famous player GVHD, the donor type, and sometimes severe lymphopenia. We don't need to fall back on cidofovir to treat this because these are usually self-limiting, and really we rarely require any treatment for adenovirus infections. So let's look at some data. So this is one of the first comprehensive studies that was published on infections in transplant patients, published from AFBMTC. There were 78 confirmed infections. Mortality was present in 13 patients. So this may be an outlier because there were only 3 patients that developed CMV in the whole cohort. All three of the patients could not make it. So this number seems like, very high, but I think it's an outlier because the number is very small. But 90% developed febrile infections. And if you look at the list, it's again the gram positives dominating at the top, followed by gram negatives, as you've seen in the international data as well. So this is something that we published back in 2014 in 108 patients. So there we documented 205 febrile episodes, out of which culture positive episodes were 40. And these are the 2 bloodstream infections and the line infections that we isolated. So in BSI, our data is a little bit different. We had gram negatives topping the list, whereas in CLABSI, it was the gram positives that were topping the list. 26 isolates in both. There was about 2 or 3 patients that succumbed because of the infections, but all in all, these patients did eventually well when they were treated with the appropriate antibiotics. So our transplant program is 2 decades old. This data was in the first decade, and this is a recent publication that we published last year. So you see, not much has changed. We're still, the gram negs are still dominating our list, whereas the gram positives are way down. But something that we see more frequently is the CMV infections. And this is not because the infection rate has gone up. It is because our diagnostic modalities and our monitoring of CMV infections has gotten better with time. Again, this is from a pediatric transplant unit in 95 patients, where they found that about 54% of the patients had developed post-transplant infections. 17 were cured, but 26 patients rejected their graft because of the infections. And about 26 or 27% patients also expired. So high mortality, but it's a small number seen in pediatric patients. And of course, this data needs to be mature in order to reach a conclusive outcome. But yes, the rate of infections was very high in the study. Again, this data looked particularly at respiratory viral infections from AFBMTC. The diagnosis was done through multiplex PCR, and the rhinoviruses, the adenoviruses, topped the list. And they were self-limiting. None of the patients required any antibiotic therapy, any antiviral to get this sorted. This is something that we published, the frequency of varicella zoster virus. This was a case series of 10 patients. So the type of involvement was thoracic and lumbosacral. None of the patients had very extensive dermatome involvement. But if you see, most of the patients developed the infection when we stopped the immunosuppression, and when we stopped the antiviral therapy. So look at the day at which they develop. This patient with aplastic anemia developed it at day 631, when this one developed at day 667. So zoster can happen anywhere during life. That's what this data told us. Because, when these patients presented to us, we were not even thinking that they would develop zoster at this point in life when, they're 2 years or 3 years down to transplant, but they did. And they all got better with antiviral therapy. This is a very recent publication on dengue virus from NIBD, dengue virus infection in transplant patients. Again, this is a case series. All of the patients tested positive for dengue antigen except for one, which had antibody positive. Because it's only 9 patients, this number again looks to be really big. So this basically means that 2 patients succumbed because of dengue virus, but I'm sure there were a lot of other factors that were involved that caused a mortality rather than the dengue infection alone. Prevention. So prevention is better than cure, we all agree. And we know that all the transplant practices, like your patient being isolated, the use of HEPA filters, laminar airflow, cleaning into transplant uric, we wearing PPEs, proper handling of lines, antimicrobial prophylaxis, neutropenic diet, everything promotes towards prevention of infections. And I've put this here purposely because this is something that AQ keeps bombarding us with every now and then. If you ask me what is one single thing that can prevent this, prevent infections in transplant patients or any patients with hematological disorders, it is actually proper hand washing. So this needs to be in the center while everything else circles around it. And last but not the least, the antibiotic stewardship program, because we as physicians tend to go overboard in using antibiotics. And of course, our ID colleagues are always there with a hammer over our head, where we don't listen to them and keep continuing the antibiotics when they're not needed to. But ASP really, really helps us in, tailor making the antibiotics to that we use in our transplant patients. So there has to be accountability. There has to be a pharmacy expert that takes care of this. If there are implementations or intervention, then they have to be documented, tracked, and of course they have to be reported. And the most important part over here is educating the physicians on how to use these antibiotics. So these are some key interventions that AKU took. Combinations, they used to stand on our head to ask us whether you want to continue the antibiotic or not, and then few antibiotics that require prior authorization like linezolid and tetracycline. And this is one of the antibiograms of CRE that AKU publishes every now and then. This is a yearly report. So this is a CRE with all the antibiotics that the organism is susceptible to. So in summary, we all agree that patients undergoing transplant are at high risk of infections. We all saw that. Gram-positive bacteria dominate more than gram-negative. ESBL, CRE, and C. diff are the commonly seen bacterial infections. Mucormycosis, Aspergillus, and Candida are the frequently seen fungal infections in our patients. For viral infections in the adult population, CME needs to be monitored, whereas adenovirus is more common in the pediatric population. Antimicrobial resistance is a critical threat, and we as physicians need to be aware of that. And in a good hospital and a good ID program, antibiotic stewardship is a mandatory component. And of course, infection control practices are the essential core to prevent infections in transplant patients. Thank you very much.
Thank you very much, Dr. Natasha, for an excellent talk. So we'll move on to our next speaker, which is actually a virtual presentation by Dr. Saad Usmani. Dr. Saad Usmani is a consultant hemato-oncologist. I think it's already about to start. So he's a consultant hemato-oncologist and myeloma specialist and a cellular therapist at Sloan Kettering Cancer Hospital in New York. And guess what he's going to talk about? its progress in myeloma treatment, immunochemotherapy, transplantation to cellular therapy.
Hello, everyone. My name is Saad Usmani. I'm the Chief of the Myeloma Service at Memorial Sloan Kettering Cancer Center in New York. And I'm going to be talking about managing newly diagnosed transplant-eligible multiple myeloma in 2024 and really focus on the state-of-the-art therapeutics that we practice here in the United States. Multiple myeloma is a worldwide hematologic malignancy. It is the third most common blood cancer in the world, the second most common being diagnosed in the United States. The worldwide incidence is about 190,000 new cases with 120,000 people dying from the disease. In the United States, the new number of cases diagnosed in the year 2023 was roughly 36,000 with around 12,500 people dying from the disease. And the outcomes in the United States have significantly improved over the past 2 decades, primarily because of the novel therapies that have been introduced into the scheme of treatment, as well as the access to care. In the United States, the median age of diagnosis is around 69 years, and within our population here, it is the most common blood cancer in the Black American population. So a little bit of difference in the racial ethnicity, incidence and prevalence of the disease. One thing that I want to highlight is this particular slide. I think we are going to be using this slide for the future from more historic perspective because the landscape of treatment in myeloma has changed. We've made a lot of headway in improving survival outcomes for myeloma. It's primarily driven by the scheme of treatment. We give patients initial induction therapy, evaluate them for eligibility for a stem cell transplant as consolidation, give that therapy to them, patients recover, have a response plateau, and they go on maintenance treatment. And we, of course, provide supportive care with pain management, infection control, bone health issues, etc. And when patients do relapse, we have restaging of the disease and then give them the best next option. But with that approach, the standard risk newly diagnosed multiple myeloma patients have an overall survival now of about 13 years. And for high-risk patients, it's about 7 years. So we've made headway, but for high-risk patients, we still have a long way to go. And for the remainder of my talk, I'll try to focus more on the transplant-eligible population, but I do want to share our approach or paradigms or principles that we are adhering to now. It's very different from what it used to be 20 years ago. We're trying to pick strategies that give our patients the best depth of response in that first year of diagnosis. We are focusing more on measurable residual disease assessments, either on the bone marrow aspect, and we're, or even in the peripheral blood, on the exploratory endpoint. We're trying to improve the depth of response by incorporating newer therapies into induction and consolidation strategies, as well as going for dual maintenance treatment. And then, we are trying to tailor these therapies in clinical trials to disease biology and burden. And we are trying to incorporate now frailty as an important initial assessment in defining what kind of treatment options may be available for certain patients. So, just keeping that in mind in the context of the patient population that you all are going to be treating. And then for high-risk patients, we don't have a lot of options or opportunities. So optimizing the best treatment strategies for those patients is extremely important. Now, what do we call high risk? That definition continues to evolve. We used to think about just focusing on burden of disease with Dewey-Salmon staging system. Then the serum albumin and beta-2 microglobulin were utilized to create the ISS staging. That too was mostly disease burden based, maybe some disease biology based with beta-2 microglobulin elevations in patients who might have normal renal function. But the revised ISS staging system and the revised 2 ISS staging system tried to incorporate some of the biologic high-risk features into this staging system, but it still remained incomplete or rudimentary because as you can see in the table on the left lower corner, there are many high-risk features that portend poor prognosis for myeloma patients. So a couple of years ago, we developed this high-risk consensus definition, which obviously is still continuing to evolve, where we are incorporating, these high-risk features in a enrichment design clinical trial and examining high-risk disease in different ways in multiple myeloma. So just something to think about as you are trying to identify, what high risk truly means in myeloma. It's both biologic as well as certain clinical features such as extramedullary disease or circulating plasma cells. Now, the schema of myeloma treatment starts with induction treatment. And the first clinical trial that actually led to the incorporation of multi-mechanism of action induction therapy was the SWOG 777 trial. This was a randomized phase 3 study looking at RVD as induction compared to RD. And this trial looked at all comers, patients who were both transplant eligible as well as ineligible, and showed both PFS and OS survival benefit. And this RVD regimen has then been incorporated into the frontline strategy. There was thought of whether we can continue RVD and just forego a transplant in the frontline setting and just use it at the time of relapse. There were a couple of clinical trials in 2009 that tried to attempt this. Both arms received lenalidomide as maintenance for a year, and this data was published almost 7.5 years ago. And the trial read out positive in favor of using autologous stem cell transplant in the frontline setting. And that outcome was predicated by MRD negativity rates being higher in the transplant arm. So it's not just about the depth of response that patients get, it's the quality of MRD negativity patients get that translates into that PFS benefit. And then the determination clinical trial was a US counterpart study that actually looked at the same question, but in the US study, the maintenance was continuous rather than for a finite duration of time. And the PFS was again primary endpoint, just like the IFM 2009 study. And this trial too read out positively in favor of early transplantation. However, one thing that I do want to point out here is the difference of PFS between high risk versus standard risk. So if you are in a low middle income region of the world, and you have finite resources, and you're thinking about, okay, do I need to develop an algorithm for patients who may be eligible for stem cell transplantation? Certainly, you can get reasonable standard risk patients, and certainly standard risk patients do benefit from the transplantation, but patients get RVD with stem cell transplantation 55.5 months. So a very important lesson that transplant remains a very important part of the armamentarium for high-risk patients. Then can we improve upon induction therapy by adding an anti-CD38 monoclonal antibody? The two proof of concept clinical trials that were done initially, the first one in the transplant eligible population was the Cassiopeia study done in Europe. And then the second was the Griffin randomized phase 2 trial that was led at my previous by my previous team and cancer center at Levine in North Carolina, where our group led this trial. Pete Voorhees from my team, my former team, led this clinical trial. And the idea was adding daratumumab to both induction and post-transplant consolidation phases, as well as asking the maintenance question. And here again, the question was, does the depth of response improve, and does that translate into progression-free survival benefit? And both the Cassio trial and the Griffin trials demonstrated that depth of response, MRD negativity continues to improve as you incorporate, an anti-CD38 monoclonal antibody, in this case, daratumumab, into the schema. And that depth of response translates into progression-free survival benefit, which was clearly seen in the Griffin trial. And with this introduction of anti-CD38, we saw very impressive OS rates. And the 4-year OS rate on this trial was almost 93%, which is quite remarkable compared to that SWOG 777 patient population graphs that I shared with you. And so, we were all encouraged to see this, but then these data needed to be validated in a phase 3 study. So the Perseus trial, same design as Griffin, but powered for progression-free survival. And unlike the Griffin trial, where daratumumab was given intravenously, subcutaneous data was given in the Perseus study. So this trial too read out very similarly. These curves are so similar to Griffin. PFS benefit in favor of the daratumumab containing arm of the clinical trial, and the OS rates very similar to what you saw in the Griffin study. So making the case that quadruplet induction made sense, and one should really think about having dual maintenance for patients. There's more data coming towards that end. But I just want to leave it at that. I'll share our practices here at MSK in just one bit. What about carfilzomib being utilized as part of initial induction therapy instead of bortezomib? Carfilzomib had already shown that in the relapse setting, carfilzomib actually has better pre-PFS and depth of response compared to bortezomib dexamethasone. Forte trial looked at KRD as induction and KSID as induction and consolidation in a transplant setting. And there was a third arm of KRD being given for an extended period of time for 12 cycles and see if it's better at all than stem cell transplantation. After all, carfilzomib is an irreversible proteasome inhibitor and appears to be more effective than bortezomib in the relapse setting. And there was a second randomization to this randomized phase 2 study of using KR versus LEN as maintenance. And so the study read out favorably in the KRD with transplant arm in terms of progression-free survival, but then you see that MRD negativity rates and sustained MRD negativity are what are driving that progression-free survival benefit. So this is where there's a case to be made of using KRD as a potential induction regimen. But are there any subgroups that benefit more from KRD versus VRD? So since we were not going to see a clinical trial that looks at high-risk patients specifically, our group actually looked at MSK, looked at VRD versus KRD for our high-risk patients. And what we observed is, regardless of whether they're transplant eligible or ineligible, KRD has better progression-free survival, which is statistically significant at the 5-year estimates compared to VRD. And the OS benefit appears to be more pronounced in the KRD and is statistically significant as well. The next important question was, okay, if KRD is giving better high-risk outcomes than VRD, what about DARA-KRD? So there was a clinical trial called the MASTER study that looked at both transplant eligible and ineligible patients getting the DARA-KRD regimen. And we had the Griffin study where we had looked at DARA-RVD. And we started looking at CR rates. This data is actually now published. Natalie Callender is actually the first author on this paper. Just came out, I think, 2 or 3 weeks ago. We looked at CR rates. They appear to be similar between patients who have standard risk, one high-risk feature, or 2 or more high-risk feature. But we start digging down into the depth of response. We start seeing the MRD negativity rates being more pronounced and higher in terms of numerical numbers as well as their durability or sustainability in the DKRD cohort of patients compared to DBRD. So, in our group at MSK, this is the schema that we follow for our transplant eligible patients. We prefer having a quadruplet induction therapy for both our standard risk and high risk patients. For standard risk patients, we prefer DARA-RVD or VRD. And for high risk patients, we prefer DARA-KRD. There is nothing wrong with giving a triplet induction therapy to either standard or high-risk patients, but you get better bang for the buck by adding daratumumab to the schema. For our standard risk patients, we still prefer lenalidomide as maintenance treatment, but again, based on some of the emerging data with Perseus, we might be thinking about things in a different way. Same thing with high risk. We prefer an PI and image-based maintenance strategy for high risk patients, but then there could be a case made for anti-CD38 with image-based maintenance for those patients. And we do consider old-fashioned chemotherapy for our patients who might have bulky EMD or PCL for cytoreduction before we go to a quad. And then in rare instances now, we actually do, maybe plan auto allos for patients in this setting. Lastly, I want to say the field is moving forward in this transplant eligible patient population. So there is an ongoing clinical trial where we're actually incorporating a BCMA-directed CAR T cell therapy called cilta-cel into the frontline setting. So the CARTITUDE-6 study randomizes patients after having received quadruplet induction to either receiving an autologous stem cell transplant or with cilta-cel, and all the patients get len as maintenance. But I think, this trial will not read out for another 5 or 6 years. And until that point, autologous stem cell transplant still remains a standard of care treatment for patients. So to summarize, for this transplant eligible patient population, I think, for any myeloma patient, I think picking the treatment strategies that give the best depth of response during that first year of diagnosis is very important for survival outcomes. Anti-CD38 monoclonal antibody quads provide better depth of response that translates into better PFS benefit. We've seen this across several randomized studies now. But in the future, I think the bispecific antibodies and biomarker-driven therapies are going to be incorporated into induction, and maybe CAR T might be able to replace autologous stem cell transplant in the future. High-risk patients don't get a lot of chances to, through different relapses. So optimizing their strategy from the get-go is extremely important. And with that, I will end my talk and give a shout out to the MSK Myeloma Service team here. It does take a village to advance the field and take care of patients. And I'm appreciative of leading this talented group here in New York. Thank you so much. Hello, everyone.
So, so with that, the floor is open for the panel discussion and Q&A session. So if there are any questions, you shout out. I might start with a question. Oh, yep, come on. If you come to the mic, yeah.
My first question is from Dr. Rajeev. Sir, as you know, you talk about a panel of 16 gene panel, and our financial constraints. We recently started doing this FLT3 in our high-risk MDS patients, and we did one patient, high-risk MDS with FLT3 positive, and later on we put on sorafenib. So what do you suggest in our constraint settings? Do we do FLT3 and TP53 in all our patients in pre-transplant, especially in high-risk MDS patients?
So even if we are looking at resource constraints, we should actually identify the high-risk mutations, which have already seen in IPSS-M, that is TP53, MLL, and FLT3. So the issue with doing TP53 in Pakistan is that the labs in Pakistan are doing del17P. So they are not looking at TP53 mutations. So even if you are checking FISH for deletion 17P, you are missing around 17% of those patients who would be TP53 mutated, but they will be FISH negative. So even if you check for 17P, that cohort would be missing. So ideally, and another issue with doing TP53 mutation is that it cannot be checked by PCR, it cannot be checked by Sanger sequencing. You have to do NGS testing for that. But you have to identify those 3 mutations, and if possible, at least these 3 should be checked.
Okay. Thank you. My next question is from Dr. Natasha. Keeping in view of a high rate of CMV reactivation, especially in our patients receiving MEC, what do you suggest using low dose Velgan cyclophosphamide like 450 milligram, or do you start it from the day -1 or +1, especially during conditioning and post-transplant?
Okay, so the drug of choice now is letermovir and not valganciclovir for CMV prophylaxis for now. Those are the latest guidelines. But then the studies published previously before this have also said that it is the reactivation that matters. So serial monitoring, if you have the expertise of doing serial monitoring of CMV, then you start Valgan or ganciclovir when the CME viremia tends to occur. And then not just one reading, it has to be a serial monitoring. So for example, on day 15 or day 16, when your patient has engrafted and you see that the viremia has 1,000 copies per ml, repeated in the next week. And if the viral load starts to increase, that's when you initiate ganciclovir or Valgan. Because remember, these patients are still going to be pancytopenic, and ganciclovir or Valgan can cause suppression of the bone marrow, leading to suppression of the graft as well. So it's serial monitoring. Then you start Valgan or ganciclovir. Otherwise, acyclovir till CMV is not reactivated or not positive, you don't need to start it. I think that was the same question that was asked. Yeah.
Okay, and secondly, while working in Gambart, among infections, we are dealing with fungal infections. I mean, 3 of our patients died in a sequelae, and on postmortem biopsy, it turned out to be a case of Fusarium. So in a small group of patients, we are using combination of antifungal, like the available agents. We usually use voriconazole along with amphotericin. And we have changed our conditioning protocols as well. We use amphotericin right from the beginning of conditioning. So what I want to know, what's your experience, especially in fungal infections, how to treat that patients? Are did you change your prophylaxis regime or not?
So when we were using fluconazole or itraconazole, we used to see a lot of fungal infections in our patients too. But since we introduced voriconazole, the infection rate of fungal infections has started to go down. B, we rely on the testing of galactomannan and BDG. So they're very sensitive. And as soon as we see that they've come out to be positive, and if you're suspecting fungal infections, that's when we change our regime from voriconazole to whatever drug, suits, if it's candidiasis or aspergillus. But voriconazole has really, gotten down the rates of fungal isolates in our patients. Yeah.
Thank you. Any other questions? I have a couple of questions if no one else has questions. So first one for Dr. Rahil. We occasionally get these Del 5Q MDS patients as well, which has, a good risk and very, good responses to lenalidomide-based treatments. But it's not uncommon to have, another cytogenetic abnormality or P53 mutation with it. So I think 10 to 20% will have P53 as well. So would you treat them any differently if they have got, say, P53 mutation along with them? Would you go for an early transplant or not?
Definitely, yes. So I recently there was a symposium in Karachi as well, and I shared one of our patients. So he was initially deletion 5Q and deletion 12P, and we stratified him as low risk on RIPSS score. The family was affording. We sent a myeloid gene panel, and he was positive for TP53. He was positive for ASXL1 and DNMT3A, and he was very high risk on IPSS-M. And we transplanted him. So once TP53 comes in, so these patients would become high risk. And then with TP53, another question of whether to transplant them, whether it is biallelic, monoallelic, what is the VAF frequency, and all these things will jump in. But definitely once it is TP53, it becomes high risk.
So the test that you did, does it tell you about biallelic or monoallelic?
Yes. So we
we
got it done from Centogene. It is a costly test. So currently we are sending it to either GeneTAC or Centogene. So we send it to Centogene. It cost around 3.5, but they do tell us about. So if we emailed them, they do told us it was a monoallelic. The VAF value was around 60%. So it was a high VAF value with monoallelic. We transplanted him, and then he had a dip in chimerism, and it was a haploidentical transplant, and then we tapered immunosuppression. He's fine right now.
So initially starting off with lenalidomide and then taking.
What we do at our center, if patient is even del 5q, we do not start upfront with lenalidomide. This is in accordance with the European approach that if we calculate Nordic score, if it is a low risk MDS with the lower Nordic, even if it is del 5q, we start with the erythropoietin. And
after that.
And after erythropoietin, we add lenalidomide. And for junior colleagues, the dose of lenalidomide in MDS should be a very, very low dose. Otherwise, it crashes count. And do not use lenalidomide if there are 2 or more cytopenias, because if there are 2 or more cytopenias, patient will crash.
And one question from Dr. Usman Ahmadiyya.
Usman here. I just want to have your further views on low risk MDS and allotransplant, because you shared some data as well. And depending on which risk stratification you normally use, the median survival is 3+ years usually in that context. And the data was actually reflecting very similar, like 3.5 year median survival as well. So I wanted your elaboration on that.
So basically, the data that was 3 year survival was the comparison of transplant patients who received transplant from that cohort. So that is why it has not become a standard recommendation. But if we look at the data, especially with IPSSM, as we have seen, around 1/3 of our patients would be up-categorized if we use IPSSM, which is not available with us. Moreover, most of our patients are younger patients. They are likely to progress. And once our patient, even at our institute, I don't know the correct figures, but once a patient, the median age at transplant is 30 years. It is not that all our MDS are 30 years. It is because of a selection bias that we, in Pakistan, all the transplant centers do not transplant. Mostly patients who are more than 55 years of age. And the early transplant, and these patients, if they are diagnosed with MDS at 35 or 40 years, they are likely to progress. So early intervention, I think, in selected cases should be preferred, especially those patients who have severe cytopenias. So rather than giving, because we do not have luspatercept, we do not have other telomerase inhibitor. So rather than waiting them for progress or giving them HMA initially, another slide which I do not show here was the impact of transfusion burden. So once you transfuse MDS patients and they develop high ferritin, then it is one of the major poor prognostic factor. So selected low-risk patients, especially those who have severe cytopenias, I would suggest an early transplant. I would request Dr. Ayas further to elaborate. His opinion is that. So what he thinks on that.
Bias is use transplant as a last resort therapy. Especially in MDS, I don't even tell patients they have cancer. It's still controversial, especially somebody in low risk MDS has never had a transfusion. We're just talking about a P53 or deletion 7 or deletion 5q. So I think in our setup, younger patients, I can understand median age of MDS in US is 72 years. I would, in transfusion dependent patients, I would offer a transplant. Unfortunately, the modern algorithm for MDS, AML, myelofibrosis cannot be carried out without doing NGS. To risk stratify patients, you need to have an NGS panel, which majority of patients, even in your center, is 4%, which I think is universal. So I feel a conservative approach. Again, that's something that bothers me as a clinician, is that presence of dysplasia in marrow is not myelodysplastic syndrome. Presence of fibrosis in marrow is not myelofibrosis. You can see dysplasia, and so the diagnostic dilemma when you have a normal cytogenetics and FISH is negative for the common mutations we check, being stuck with a patient who's never been transfused, even if he comes in as intermediate 2, I transplanted 57 years old high risk MDS 3 months ago. Developed mucor of the lung, ended up with a pneumonectomy, died 2 months later. So even in best centers, the survival, as you said in the beginning, is 40 to 50% range. So I have my bias of transplanting MDS only when it's an IB2 or we see impending transformation or the patient is transfusion dependent. I think in our setup, the cost effectiveness of this disease, but we do see a lot of young patients, which I never saw in US, the 25 and 30-year-olds who are coming in with the florid MDS. So that population, I think we should transplant. But otherwise, I think my bias is that transplant should remain a conservative strategy in MDS.
Yep, Dr. Zala.
I'm just intrigued by your, the population, the 30 to 54 years old. One of the issues that we see in the bone marrow failure space is that it's very difficult to make a diagnosis of aplastic anemia versus hyperplastic MDS. And that really relies you getting a very good fish. And fish is a test which is also notorious for a lot of variability. You have got 3 people looking at fish, and then counting the number of cells. So it's not hardcore science, so I think genomics become very important. And the way in our settings, we rely on these, extra myeloid mutations and TP53 to distinguish. And one of the things we do in a lot of our patients is look for a PNH clone, because a lot of these patients will have a very small clone. And if they do have a clone, we tend to go towards the aplastic route rather than going towards the MDS route. So I just wanted to have your comment on, because definitely in our practice, we're seeing a lot more MDS in the elderly population as compared to the younger.
So that is absolutely right. So just carry forward the same point which Dr. Ayaz was saying, that one of the reason for a younger age group of MDS, a couple of reasons. One is that our population pyramid we know is like this. In Western countries, it is a top narrow, bottom wide, but in Pakistan, it is just like, so in the middle tier is most of our patients are younger patients, so we're likely to get more disease. And secondly, that inherited marrow failure syndrome is very common in our setup. So it has to do with the toxin exposure, and it has to do a lot with our genetics. There are a lot of consanguinity, and especially there are specific cohorts in pockets like Southern Punjab, like KPK. So our center has around more than 3,000 registered aplastic anemia patients. And we published a study a couple of years back in which the transformation rate was around 15%. So these patients will transform into MDS. These patients will transplant into transform into AML. And we know that the transformation is not from a non-severe aplastic anemia to severe, very severe, and MDS. It is a clone that is acquired, mostly in non-severe aplastic anemia patients, and they will jump ahead to MDS. So they will never present with transfusion requirement. They will never present with bleeding, and they'll present with MDS at younger age. And secondly, that is why a slide of germline testing was added, because we frequently saw the increased conditioning toxicity in our younger patients as well. And once now we look at our retrospective data, we see and we believe that these were the patients who had MDS at 25 years of age, and why they should have a renal failure with BUSI. So most likely they were that cohort we missed, and these were inherited marrow failure syndrome.
So I have one question for Dr. Natasha. So so in our hospital as well, we have a huge problem with these carbapenem resistant gram-negative organisms, especially E. coli. In fact, you showed your antibiogram. In our antibiogram from last year, we had about 2,000 plus E. coli isolates, and about 25% were carbapenem resistant. And what we've seen in our practice in our transplant and leukemia patients, as soon as they hit the mucositis phase and neutropenia, they have a VU spike, then the blood pressure drops down. And if they end up in ICU, there's a high chance they're not coming back. So we changed our practice. We are actually adding in colistin and increasing the meropenem as soon as we get to that phase. And if there's a hypotension, there's a GNR growing, because the actual sensitivities will take another 48 hours or so, and we don't have that much time. So what is your practice at Aga Khan dealing with the gram-negative septic episodes?
So what we've started doing now is so we've got 2 cohorts of patients. One are those who are pre-sensitized already. For example, leukemics, which were previously admitted in the ward, developed CRE. Although the clearance cultures have been negative when we're taking them into the transplant once they've achieved remission, but we continue the hand hygiene and all the infection control practices, even though the clearance cultures are negative, because the standard guidelines say that you need to continue the practices at least for a year. So we do that in those patients who have had a positive culture for CRE. For those who are negative, and we know that they will eventually develop life-threatening infections, what we've started to do now is that as soon as they hit ANC of less than 200, which usually happens on day +3 or day +4 or maximum by day +5 of transplant, we switch them to meropenem single agent rather than continuing with the fluoroquinolone. Although the ID guys are not happy with this approach, because they're saying that we're causing a carbapenem resistant to increase, but then we've seen that as soon as because what happens is we all know that all mucosal barriers are down at an ANC of less than 200, and they're bound to cause gut susceptibility from the bacteria in the gut that would come into the bloodstream. So we preemptively start meropenem as soon as the ANC goes to less than 200. And we continue that till they start to engraft. And as soon as they hit engraftment, we switch them back to fluoroquinolone. This has gotten the incidence of CRE down drastically, because we don't let I mean they do become neutropenic, but the incidence or the frequency of infections has gone down. Once the frequency of infections have gone down, CRE has also gone down. And of course, we've emphasized a lot on our hand hygiene and practices and taking care of the lines, everything what the ASP does. But this is something that we've done, and that has gotten the incidence down. And when CRE does happen, when the isolate is there in the bloodstream on the line, then we also do the same thing. We do a synergistic combination. We do colistin and meropenem together. And then sometimes we also switch to fosfomycin when the patient is stable enough and we're discharging him or her. We switch them to oral fosfomycin till we wait for clearance cultures to get negative.
And what about the colonizers or who've had it previously? And they've had CRE in the past.
Yes.
So obviously meropenem on its own is not
Fosfomycin, oral fosfomycin, the
Yeah.
colonizers, oral fosfomycin. Yes. Yep. That's what we do.
Thank you.
Same comment here and a question as well. Very similar question to Vikas. That in our center, we are kind of keeping a low threshold to start any peptides or meropenem rather than a upfront at this point of time.
Right.
It does explain that in your data, you had gram-positive septicemia more.
Yes.
On the contrary, we are seeing a more gram-negative bacteremia in our transplant patients. And that
Right.
does explain, I think there's a
Why?
bit of practice variation as
Yes,
well.
yes, that's how it's changed. So we used to have gram pos too, but gram negative too. But because of this introduction of the drug, it has gone down. Yeah. Actually, it's the line handling that needs to be taken care of, and the hand hygiene. If that works well, then the incidence goes down.
Is Dr. Saad Usmani online, or
Uh,
maybe all of you can?
I'm not
answer
sure. We
if
can
you-
ask. Is Dr. Saad, are you with us online?
Okay, so regarding multiple myeloma, as you said, whether there's transplant eligible or ineligible, we try to get as much MRD or as much disease control as possible. So from practical point of view, for non-transplant eligible patients and older patients with the available drug regimens, how deep a response you practically achieve or aim for? Biochemically, on markers or otherwise, because many of them will not go to transplant. And if you leave them with a little bit of monoclonal band or serum free light chain, we see some of them just blow up later on. So practically, how do you approach that?
The free light chain ratio is normal, if as per this ratio of 1, as per 0, or it depends on the goal. If it's somebody who's 80 years old and in RD, you don't have to be in VGPR or pregnant CR or CR. It's quality of life issue. I tend to use a lot of oral cyclophosphamide, lenalidomide, pomalidomide, etoposide tablets. Yeah, I tend to try to keep them out of hospital for any reason, not even for I use Exazum a lot. I have like 30 patients on Exazum. So I tend to use oral regimens in transplant ineligible patients where goal is obviously prevention, keeping them out of hospital. And I don't do after MRD or marrows. I think I hardly do a marrow after the original one. Because I feel we overdo that. I can understand somebody at the Memorial or Mayo Clinic or a lot of the time they are doing all these testing. One of my patients goes to Baylor, he has stuff. Every time he goes there, every 3 to 6 months, they do a marrow with NGS. Every single time. And then they find 3-4 variants which they don't do anything about. So I think a lot of the tests being done in US and Western Europe are because the academic centers are running clinical trials and they tend to overdo things. I think we should limit. I just saw a myeloma patient last week who had 6 bone marrow biopsies this year. I think that's torture.
Dr. Ahid?
Thank you very much. Just wanted to share our experience. So we are also facing a lot of problem with CRE. So what we started doing a couple of years back with our ID colleagues that before taking our patient to transplant, we do their stool surveillance sampling. So we check their stool sample for CRE, VRE, and ESBL. And we actually, once they are admitted, we know that they are colonizers. The contact precautions are different for this cohort of the patient. And secondly, once they start spiking fever, so after 48 hours, if they still spike fever and we don't have culture, we start with them on colomycin. So colistin is a go-to. So what we are doing that on the basis of that stool surveillance culture, we are adding earlier colistin, because we had a lot of discussion with our ID colleagues, and the concern regarding early use of carbapenem was that down the line, couple of years later, this will induce more CRE resistance, because even if you use meropenem and your hospital is having more than 25% CRE positivity, it will result in further blow up of CRE positivity in the future. So we do not test them afterwards. Yes. So before we have included it as a part of our pre-transplant assessment. So in pre-transplant assessment, we send them for stool surveillance sampling. It does not cost more than 2,000 rupees. And we have CRE, VRE, ESBL colonization status at our hand. So we do special precautions like the cleaners who are looking after that rooms, they would be dedicated. We counsel the patient and attendants more that they are already colonizers so that it is not spread. And once they started spiking fever, we have a low threshold. We do not, even if they are colonizer, we do not start them on upfront colomycin. But if they are febrile 48, 72 hours down the list, we start them on.
Yeah. I think that's very good input from Dr. Rahil, because I think this is the same trial which we are looking at, that if we can develop a trial where we have got a very similar approach. And I think in few centers abroad, they are using this approach to get the screening of stools beforehand. Just wanted to have an intriguing question regarding myeloma. And I think the question is out open for all the experts here. That of starting second line treatment, like on which parameters normally you think that the second line treatment should be started in the myeloma patients or on maintenance? So we can start from Dr. Ayaz and then.
When do we start second line? Obviously, once you have transplanted them, the monitoring is biochemical. If I see a consistent rise, if their serum protein electrophorese, we measure it by densitometry, is more than 0.5 gram, or the light chain ratio is consistently rising in 3 sequential readings, and they are on Lannett maintenance, which most of my patients are, I would tend to go to a couple of cycles of RVD and then RV as maintenance. I don't use a high risk, Lannett bortezomib maintenance for high risk patients. And then On occasions, I add ixazomib to lenalidomide. So I double if there is biochemical trend in rising, we go for that. Correct, correct. That depends on the nature of, I've had patients come in with floral calcium of 16 and neolytic lesions. That obviously needs a reinduction. There's 17P positive patients. There was a recent paper, their median PFS is 19 months, whatever you do, regardless the conditioning you give. Dara is like fourth line for me, just because of cost, and not only cost, also because of the quality. The Dara I get has been sitting in a dark room in a sack somewhere at 45 degrees. I don't know if it's intact. So it's not just the cost. The cost now is like 50,000 in black market for a while, but the quality is same for carfilzomib. It's not just the cost. The carfilzomib we get, hardly half of my patients respond to carfilzomib, which was not the case in US. It's a very good drug, at least in white people it is. Amazing combination, but not in Pakistan. So I don't know what Colonel Rahil's experience is.
So our practice is a little bit different. So what we do is that we try to achieve maximum depth of response before taking our patient to transplant. So we have a bias for that. So we'll start with a triplet therapy in most of the patients, a quadruplet in a rare one. So we collected data, and I think a couple of patients used upfront quadruplet. So initially we start with triplet. Our preference is RVD. And if the patient has not got into complete remission, for partial remission, we actually switch early and we introduce carfilzomib early in order to get the patient into remission. And post-transplant, if we are taking patient to transplant in complete remission or VGPR, we do not give them any consolidation post-transplant. And we do maintenance on the basis of initial ISS score or RASS score, that doublet for high-risk patients. So no. If the patient has, so what we are doing that after 2 cycles, we start with biochemical monitoring. So if the patient has got into remission or is a responsive disease, we try to take them to transplant after 4 cycles. Now we have liquid nitrogen available with us. We try to collect 2 doses for transplant. So we'll transplant with one and we'll cryopreserve another. And if we have not taken transplant, if the patient is not in complete remission at the time of transplant, then we consolidate them post-transplant. Otherwise, we do not. And then maintenance would be again depending upon initial next treatment. So we do not start treatment on biochemical relapse post-transplant. Only if there is a CRAB criteria that patient is fulfilling. Yes.
So this is exactly what we do as well. Get the highest depth of response before taking them up for transplant. And then post-transplant, of course, maintenance. And then serial monitoring. FLC is a great tool. We don't do bone marrows. Just like you, I think we will only do bone marrows at the initial stage when they present to us. But if the FLC tends to show rising trend along with CRAB, so we don't tend to, start treatment just on the basis of rising FLC plus CRAB. If that happens, if that is the combination, then we initiate second line.
Spend so much intensifying so much prior to getting the transplant. Afterwards, we just wait for the CRAB rather than when we see it's.
The main reason is that post-transplant, we do not have any options available with us. So once we have exposed the patient initially to lenalidomide, bortezomib, and post-transplant, if there is an early relapse, we know that if the patient is relapsing within 12 months post-autologous transplant, or in some studies up till 24 months, so whatever you do short of CAR-T or bispecifics, they will not work. And we have seen in our patients that even if they have got a biochemical relapse, they continue to have a very good quality of life. And the biochemical markers will keep on fluctuating up and down for even months and years. Definitely an exception would be a patient who has got a FLC that is going a steep high, or who has got a paraprotein band that is jumping up. There'll be an early intervention.
Yeah, that's exactly, I think, what I generally tend to do in relapse setting as well. So I don't sort of start treatment based on biochemical relapse. But what I've done is if they're on 10 milligram lenalidomide, I bump it up, go to, full 25, add the dex back in if they've come off the dex. And quite often what I find is that that does the trick for many months. That's exactly like what you were saying. I don't think there's any extra added benefit of starting treatment in lab setting early just on basis of a biochemical rise. So I think it's nearly 1 p.m. and I hope everyone has built up a good appetite. So we'll sort of come up to a close now. So I'll thank all the speakers, also Dr. Ayaz as well. So we'll go for lunch. Okay, thank you very much.